Welcome to CPI 101, Patient Safety. This is the third in a series of modules that are providing the introduction to continuous process improvement at UCSF Health. My name is Audrey Linden. I'm an associate professor in the Department of Family Healthcare Nursing in the School of Nursing. I'm going to lead us off today. One of the questions that you might have is, why are we talking about patient safety today? Or why do we need to be worried about this? Well, in 2000, the Institute of Medicine produced a really important report about patient safety. One of the things that they identified in this important report is that there are a lot of deaths that are caused by medical error. One of the things that we've learned over the last 15 to 20 years is that what we need to be thinking about are the systems that contribute to patient error. So that's an important shift that's happened over the last few years, is moving away from blaming individuals and developing our understanding of hospitals, healthcare systems, and ambulatory care. The goals for our module today are to understand some of the fundamental principles of safety science, to identify how system defects can place patients at increased risk of harm, and to learn some strategies and safety concepts that can be applied to minimize risk and prevent errors. So first, let's talk about what we mean by medical error. Medical errors are anything that results in harm to a patient. So this might be a situation where a patient gets the wrong medication, where they slip and fall out of bed or trip over something in a outpatient office. That also can be things where we have a problem that isn't what's supposed to happen for the patient, but it's caught in time. So an example of that, this is called a near miss or close call, and an example of that would be the wrong medication is ordered for a patient, but someone notices and doesn't deliver that medication. What we're concerned about in terms of patient safety are those near misses, but in particular, we're concerned about adverse events. These are the events where harm has reached a patient. And in some situations, this may not be actually a result of a mistake. It can also be there are certain aspects of care that end up with negative consequence for patients that isn't a mistake. But there are mistakes that reach patients, and those are what are considered preventable adverse events, as opposed to the things that are just truly a consequence of medical treatment and are not preventable adverse events. Let's talk about how these errors can occur and result in patient harm. Our healthcare system is complex. Most complex systems have multiple layers of defenses to keep bad things from happening. So one of the kinds of defenses that we have are safeguards. Safeguards are technical solutions to help us do the right thing and keep us from doing the wrong thing. An example of a technical safeguard would be, I have a relatively new car, and in my car has one of those great navigation panels and also a backup camera. So the backup camera is a safeguard that helps me see where I'm going when I put my car in reverse. Then it also has the thing to keep me from doing the wrong thing, which is that when my car is in reverse, I can't enter any navigation or GPS data on my screen. It stops me from doing that. So that's what we mean by kind of technical safeguards. Then we also have multiple other layers of defenses. For example, having policies around stopping the line when something is going wrong, using standardized work processes, as we discussed in the Lean module, and flexible staffing and self-checks on how we're doing our performance. The problem with this kind of thing is that every layer of defense has these defects, and in fact, most layers of defense have multiple defects, and we can't always anticipate what these are or know where they're coming from. The kinds in a healthcare system, the kinds of defects that we might see would be failures in the kind of culture that we have, the policies that we've written, the resources that we are or are not providing to our staff, breakdowns in training and communication. These can all create multiple holes in our carefully designed layers of defense. Most of the time, this isn't a problem because in most situations, everything lines up just right to prevent any one of these defects from getting all the way through the system. But every so often, everything lines up just wrong, and an error gets all the way through these layers of defense and reaches the patient. So the important thing I think we need to remember from this Swiss cheese model of accident causation, which was developed by James Reason, is that we don't know what all the defects are in our system, and we can't always predict how things are going to go wrong. This means that we have to be preoccupied with safety, that even with our best efforts, errors are still going to occur. This happens for a number of reasons. One of these reasons is that we have emerging safety risks. We have new technology and new processes happening all the time, and we don't know where all those defects are in our layers of defense. Similarly, our systems are complex, and the different parts of our systems can interact with each other in unpredictable ways. And finally, the very things that make us great problem solvers, as in the way the human brain works, also make us prone to making certain kinds of mistakes, forgetting things, skipping steps. This means we have to build resilience and be on the lookout for potential harm all the time and make sure that we have a system that allows us to learn from defects in our processes. Another reason we have to be preoccupied with safety is something called the normalization of deviance. This happens in work groups when the standards slowly degrade over time. Or sometimes people start taking shortcuts or using different ways of doing things. And when they do that over time and nothing bad happens, people start to believe that the way they're doing things is safe. Some people might be feeling a little discouraged about our ability to improve safety given all that we've been talking about system complexity. The good news is that the principles we've been learning in the first two modules can also be applied here. A good example of that is the hand hygiene project that Dr. Ranji talked about in the quality improvement module. The lack of hand hygiene represents the normalization of deviance in healthcare. By using a systems approach, going to Gemba, and getting all the relevant personnel involved, UCSF has been able to change the culture and the infrastructure around hand hygiene so that there's now a new social norm where clean hands are the baseline expectation and our staff are stopping the line when they notice a lack of hand hygiene. We can do the same for any safety problem. It's a matter of first identifying where we have defects in our system and then taking a systematic approach involving people and solving problems in a programmatic way. So let's take a minute to review. If we had a situation where the wrong patient was taken to a department for a procedure, which of the following could have contributed to the event? If you answered all of the above, you were correct. The really important thing to remember is that everyone has a role in patient safety. Everyone from the admitting clerk to the respiratory therapist, laboratory personnel, nurses, physicians, surgeons, you name it. We all have an important role to play, and the next thing we're going to talk about is strategies that we can use together as a team to keep patients safe.
Hi, my name is Jim Stotts. I'm the Patient Safety Manager here at UCSF Health. Oftentimes, people hesitate to raise concerns because they have fears of consequences. They're worried that other people are smarter than them and would have said something if there was something wrong. And so they hesitate when there was an opportunity to maybe prevent that event from happening. Silence conveys agreement that maybe something wasn't wrong or some error isn't occurring. Making other people aware is creating a learning environment, and it helps us all be accountable for what's occurring and improves our safety culture. Therefore, when something doesn't look right or hear right or even feel right, that's the time to take the initiative to speak up. A highly reliable system values diverse opinions and creates opportunities for people to be heard. We all have an obligation to listen when concerns are raised. Consider using a phrase such as, "Can you clarify for me?" when something is wrong and just doesn't seem right. Once clarification has been achieved, then together as a team you can reach consensus about what should be done next. A highly reliable healthcare organization pays attention to and responds to faulty work processes. Learning from defects is a necessary part of improving the culture of patient safety. We do this in two ways. We look forward and we look back. One way of looking forward is using a method called failure modes and effects analysis, or FMEA, to identify failure modes, or how things could go wrong, their consequences or effects, and put into place processes to prevent them. We learn from defects that have already happened in a number of ways. We trend data to look at actions that can be prioritized. We examine system and human factors associated with events in a root cause analysis meetings, or an RCA, so that system improvements can be implemented. We examine clinical care and adherence to practice standards in case reviews. We also conduct retrospective reviews of cases that have resulted in lawsuit or claims that takes into account both internal and external factors, so that action plans are developed to prevent similar events in the future. You may be asked to participate in an FMEA, an RCA, or a retrospective review. Lastly, sharing stories prepares us for future situations. It's important to remember discussing specific patient identifiers should be restricted to only settings protected under California Evidence Code 1156 and 1157, such as formal department quality or safety committees. When an organization is highly reliable, it means that care is delivered accurately and safely every time. A highly reliable organization is one that is preoccupied with identifying and reporting defects. Perhaps the most important thing that you can do to help improve safety at our institution is to report errors and events when they occur. Every good catch is an opportunity for us to make our systems better. To fill out an incident report at UCSF Health, you can go to the icon on the clinical desktop, or you can go to the CareLinks link, or you can go to the Citrix link when you're trying to connect with a Mac or a computer outside the UCSF firewall. Disclosure of events is part of learning too, but it is also ethically prudent, and it's California law. At UCSF Health, it's the attending physician who's the person who should conduct disclosure discussions. But all providers can assist and should understand the basics. When an untoward event occurs, it's okay to show empathy and to convey condolences. Anyone can be involved in a patient safety event. Sometimes it's inconsequential, sometimes it's catastrophic. Should you experience a situation that is difficult or you're having difficulty coping with, contact the Student, Faculty, and Staff Assistance Program, or talk with your manager, your program director, or your service chief. Strategies used within safety actually fit well with the lean methodology. We can reduce waste by simplifying processes, decreasing distractions, and improving on or eliminating inefficiencies in the work environment. We can adopt new ways of working by reducing variability, increasing reliability, and improving team performance. And lastly, we can create ways of continuous process improvement by incorporating visual cues, checking behaviors, and automation. In conclusion, we've talked about several ways in which you can participate in improving patient safety here at UCSF Health. Report events when they occur through the incident reporting system. Speak up about safety concerns and encourage others to do the same. Watch for defects and don't be persuaded or intimidated by peer pressure to do the wrong thing. Participate in FMEAs and RCA meetings or retrospective reviews. Complete the culture of safety survey when they come out so that you can play a part in improving the culture of safety. And then lastly, support patient safety planning and the implementation of action plans within your department or work area. Feel free to contact the patient safety department if you have any questions or want to talk more about what you've learned in this module. And listed here are a couple websites that have information such as stories or guidelines or helpful tips about how others have implemented patient safety strategies in their environment.
Hi, I'm Adrienne Green, Chief Medical Officer for Adult Services and Vice President for Patient Safety here at UCSF. At UCSF, we take pride in the exceptional care that we provide to our patients we strive to deliver that care in an efficient, highly reliable manner so as to achieve zero harm. As you have heard, characteristics of highly reliable organizations with strong safety cultures include a preoccupation with identifying defects, a culture that fosters speaking up when things don't seem right, resilience in problem solving, empowering people at the point of care to take action, and supporting providers and staff who experience an adverse event or outcome. Activities that promote transparency and reporting of near misses and errors help to maintain our focus on systems improvement. Similarly, being attuned to defects and feeling comfortable stopping the line are characteristics of organizations with strong lean management systems. In order to illustrate the impact of stopping the line, I would like to share a story from our UCSF Great Catch program. We started the Great Catch program in 2014 to formally recognize staff, faculty, and trainees who have reported defects and taken action to prevent or mitigate harm. But first, I would like you to imagine that you are a patient who has entrusted UCSF with your care. Imagine yourself in a hospital bed with an IV through which multiple medications are flowing. Now, imagine being told by your doctor or your nurse that an error had just happened, and one of those medications running through your IV was actually intended for another patient. My story is about a nurse who prevented 2 such medication errors. Due to a labeling error, 2 IV bags, 1 insulin and 1 heparin, were sent to the wrong patients. Insulin and heparin are both high-risk medications which can save lives when used as intended, but which are quite dangerous when administered at the wrong dose or to the wrong patient. A nurse who was expecting a small bag of insulin received instead a bag of heparin and questioned why the bag was so much larger than the typical insulin bag. Even though the label indicated the bag contained insulin for her patient, she felt uncomfortable and took the time to call the pharmacy before hanging the bag. The pharmacist immediately recognized the error and called to the other patient's unit to stop the insulin from being administered to the wrong patient. While we celebrated this great catch that prevented 2 serious medication errors, we also performed a thorough root cause analysis to understand what processes contributed to the labeling error and put into place new standardized processes with safeguards to prevent a similar error from happening in the future. I hope that this video has provided you with a foundation for patient safety that allows you to look at your work and your work environment through a new lens. Our systems of care will only be highly reliable, and we can only achieve zero harm if all UCSF faculty, staff, and trainees understand and contribute to our culture of safety, just as the nurse in this example did.